features of the adenoma. Then what are the risk factors of colorectal carcinoma, especially our lifestyle, how our lifestyle can affect our colon mucosa to go into the neoplastic transformation. Then genetic basis of the colorectal carcinoma, like we need to see the what is adenoma carcinoma sequence. Okay, then how do you differentiate between sporadic and inherited cancers. Then knowledge of the malignant tumor, different types of tumors of the colorectal carcinoma, the features of benign and malignant tumors of the colon. Okay, so what do you mean by polyp? A polyp or a polypoid lesion are the inflammatory masses or tumors arises from the submucosa or muscle coat but protruding into the lumen. Okay, so it is the projection, a finger like projection of mucosa, submucosa, or muscle coat that protrude or that hangs into the lumen, or that it can be seen as an elevated lesion in the lumen. The polyp could be inflammatory or could be neoplastic. Okay. Polyposis, what do you mean by polyposis? Polyposis means multiple polyps. Polyposis syndrome is hereditary. Whenever you call it is a polyposis syndrome, it is always hereditary, characterized by presence of multiple pedunculated. What do you mean by pedunculated? A polyp which has a stalk or which has a connection, which is more elongated, a stalk like a tree. You have the bark of a tree and the leaves. Okay, so it has a stalk, and the sessile, which is just a flat elevation like a stone kept in a pipe. Okay, it's just a flat elevation, and it can be benign or malignant. Okay, so polyposis syndrome, polyposis, and a polyp. Okay, so what are the different types of the colonic polyps? Okay, we have non-neoplastic polyp. Okay, what do you mean by non-neoplastic? These polyps, they don't have a tendency to the malignant transformation of the same polyp to go into the carcinoma. Okay, the same polyp. What is this non-neoplastic polyp? Polyp are the hyperplastic, inflammatory, juvenile, and Peutz-Jeghers syndrome. Okay, as we discussed last class, Peutz-Jeghers syndrome is a hereditary cancer syndrome. This causes cancer of different organs. Okay, but does not cause a cancer of the polyp of a colon. Okay, in that case, the associated polyp is a Peutz-Jeghers polyp. Okay, or it is like what you call it is a type of a hyperplastic polyp. We can say it's like a Peutz-Jeghers polyp. Okay, so these are the non-neoplastic polyp. Peutz-Jeghers is a hereditary cancer syndrome, but a polyp in a colon is non-neoplastic. Okay. Neoplastic polyp can be benign or can be malignant. It can be arising from epithelium, adenoma. It can be carcinomatous polyp, carcinoma, or it can be other tumor like lymphoma of a GIT, which can also have a polypoidal projection into the lumen of the GIT, GIST, gastrointestinal stromal tumor, or other tumors can have a polypoidal projection into the thing. So if you have asked, mention two non-neoplastic polyp or mention three neoplastic polyp: adenoma, adenocarcinoma, lymphoma, GIST. Okay, this would be your thing. Okay, so we are going to talk about two different type of polyps, non-neoplastic polyp, which are common, and this is hyperplastic polyp and the Peutz-Jeghers polyp. Hyperplastic polyp, its name slip, it is just a hyperplasia of the normal colonic mucosa. Okay, this there is just normal hyperplasia. They get a finger-like projection into the lumen. Okay, they are most of the time asymptomatic. They are majority of them are located in the rectosigmoid, and 20% of them you can see in the ascending colon. Okay, they are smooth, they are moist, they are round, small, 0.5 centimeter, and most of the time they are sessile, not the pedunculated one. Can be seen multiple polyps with the hyperplastic polyp, and under the microscopy you see the well formed glands. and crypts lined by differentiated goblet or absorptive cells. Okay, so they are normal, absolutely normal, just only they are more in number. Okay, and they don't have any malignant potential. Okay, pure hyperplastic polyp, they don't have malignant potential. Okay, they are just like small polyp. They are asymptomatic, but sometimes they may have symptoms of altered bowel habits, and sometimes they might have bleeding per rectum. Okay, the Peutz Jaeger polyps, they are hamartomatous polyp, means there is abnormal accumulation of the abnormal tissues. Okay, they, like, it is a syndrome. You know, this is a Peutz Jaeger is a syndrome. It is a hereditary tumor, so they can be accompanied. They are accompanied by mucosal and cutaneous pigmentation. The patient will have pigmented mucosa of the conjunctiva, pigmented mucosa of the tongue, or they can see the pigmentation around the lip. Okay, or face pigmentation, or the face, or pigmentation around the genitalia. This is one of the very important feature to diagnose. You have a long scenario, and just only with one thing you can pick the diagnosis: pigmentation around the mouth, genitalia, and the mucosa. They are rare, but and their way of transmission is autosomal dominant. They are caused by germline mutation in the LKB1 gene, which encodes a serine threonine kinase. Okay, their polyps are large, they are pedunculated, they occur anywhere in the GI from esophagus to the rectum. Okay, and they have an increased risk of developing carcinoma of the pancreas, breast, lung, ovary, and uterus, but not itself in this polyp. Okay, that's why they comes into the non-neoplastic polyp. Now we go to the neoplastic polyp. So this can be benign or can be malignant. Benign one is the adenomas or adenomatous polyp. They are usually commonly seen in the large bowel. They can be seen 20 to 30% before the age of 40, and as we grow old, their incidence also increases. 50% can be seen in the age of 40. Males are more commonly affected than the female. Oh, sorry, males and females are equally affected in this. There is no sex prediction over here. They can be seen as a sporadic. They can be have in the familial presentation also. They can be a small, large, single, multiple, pedunculated, or sessile. And these are the results. This is neoplastic one. So there is definitely epithelial proliferation, dysplasia, which may range from mild to severe dysplasia, and they can also undergo to the carcinomatous changes. They can transform into the carcinoma. They are divided into their histological features: tubular adenoma, where you see the more of the tubular glands, less of the villus architecture; villus adenoma, where you see the villus architecture in the more than 50% of this adenoma; and tubulovillus is the combination of both. So we go for the tubular adenoma. That's the most common type of adenoma. 70% of the all neoplastic polyp are the tubular adenoma. It occurs sporadically as well as in the well-defined hereditary syndromes like HNPCs. As you see our case, we found 3 tubular adenoma and the 1 large carcinoma. Okay, average age is around 60 years. 75% occur in the distal colon and rectum, like rectosigmoid, sigmoid colon, or the descending colon. They are, if they are like purely tubular adenoma, they usually see seen in the single, and their size can be few millimeter to the centimeter. They can be sessile, they can be pedunculated. Okay, and when they are pedunculated, their stalk will have a central core of the fibrovascular tissue, and it's lined by the normal or dysplastic colonic epithelium. They can also have the severe dysplasia and the invasive carcinoma. Just I'm sorry, I just got a call. Okay, so these are about the tubular adenoma. They can see the dysplasia. This dysplasia can range from mild to moderate to severe, and they can have also tendency to invade and become an invasive carcinoma. Then we go to the villus. Okay, villus adenoma. They are least common as compared to the tubular adenoma. They are like usually largest and like very large. Like if you see as compared to tubular adenoma, they are larger than the tubular adenoma. They usually seen in elderly age, male female equally, and they have like symptomatic. They have like um, anemia due to rectal bleeding, and sometimes you have like they have like mucoid diarrhea, so like they are like copious amount of stool rich in mucus. Okay, and again their location most commonly in the distal colon, like your rectosigmoid area. As I told, they are larger in size. They can be up to grow up to 10 centimeter in size. They are broad. They are most of the time sessile, velvety because of multiple villus on the surface. They look like velvety. Okay, and microscopy you see the aggregates of villus architecture or hyperplasia of the villus with dysplastic cells. And you have like all degree of dysplasia, and some you have when you see a villus adenoma, you have to carefully look for the invasion, because the invasion can be seen up to 40% of the cases. Then we have tubulovillus adenoma. It has features of combination of both. Now it is very very important, as a pathologist or as a treating surgeon, you must know whether the what polyp you are seeing over here, it could be a benign or malignant. Okay, and adenoma to carcinoma sequence is a documented sequence, and it is the one of the prototype example of the multi-step carcinogenesis. So you should not stop just diagnosis with the adenoma. You must carefully look for whether it is a single adenoma, whether they are multiple. If they are multiple, whether it is association of a syndrome, whether there is a dysplasia, what is the level of dysplasia, whether it is mild or severe. If it is severe, whether there is an invasion is present or not. This is all you have to look carefully. Okay. So when you see a polyp, what is the probability of the carcinoma? One of the most important is the size. Uh, During the colonoscopy, a surgeon can identify, can predict it is a benign or malignant on the basis of the size. Larger the size, more chances of the it turning out to be a malignant. Some book reference has says 2 centimeter. If it is less than 2 centimeter, mostly benign. If it is more than 2 centimeter, mostly malignant. So size is the most important criteria. Then another important criteria is villus architecture. More villus architecture on the histopathological examination, more chances it's turning out to be malignant. Then cytological atopia or dysplasia. More severe the dysplasia, more chances of the it is going into the this thing. Okay, you can be asked like about a question, the probability of the where like mention three features of a polyp which can help to see whether it is malignant or problem, or mention probability of the neoplastic polyp. Okay, so size of the polyp, villus architecture, and the dysplasia. These are the three feature very very important, and among these three, the size is very very important. Or you can have the most of the which one of the following is the most important denominator of malignancy in a polyp or in an adenoma? Size, tubular architecture, mild dysplasia, or something. Okay, so size will be most important. As I told, this polyp can occur in the single or can be seen in the syndrome. Okay, so you have the familial polyposis coli syndrome, where you see innumerable, like to diagnose a familial polyposis coli syndrome, you must have 100, minimum 100 neoplasm, but they can be in the thousands. Okay, Polyps can also be seen not in the colon, they can be seen from esophagus to the colon, but commonly in the colon. And most of the time they are tubular adenoma. Gardner syndrome, you have polyposis coli. Along with that, you don't have the malignant transformation along with the in this coli, but you have like multiple osteomas, epidermal cyst, and fibromatosis. Turcot syndrome, you have polyposis coli, colorectal carcinoma, glioma, and fibromatosis. So these are the familial polyposis syndrome. Other one is you have hereditary non-polyposis, where you have polyp but they are not in many number. That's why we call it them non-polyposis. So to discuss one very important FAP, it is the autosomal dominant disorder. It is genetic defects on the short arm of the chromosome 5 band 21. Okay, so located on the chromosome 5. Patient developed hundreds of colon adenoma as during his teenager life also. Affected gene is name itself APC gene, adenomatous polyposis coli gene, located on the chromosome 5. You need to have at least 100 polyps to diagnose is a FAP. Histologically, they are usually tubular adenoma and colorectal carcinoma develop in 100% of the cases. Okay, and even before the age of 30. And when you diagnose this patient in a earlier age, prophylactic colectomy is the standard therapy. You ask your patient if you have to prevent to develop carcinoma, undergo removal of entire colon. But to diagnose 100 of minimum 100 polyps are required, and they must have tubular architecture. Okay. Neoplastic polyp, we discuss about the colorectal carcinoma. Now the epidemiology. Colorectal carcinoma is responsible nearly 10% of the all cancer death worldwide. It's the third leading cancer in men and the second leading cancer in women throughout the world. Okay. First, third leading in the men and the second leading in the women. Colorectal cancer is the second most common cancer after breast cancer in the generals of the population. Okay. If you look generals of the population, most common cancer, forget about the sex, most common cancer in the generals of the is breast. Second most is the colon. And both of these cancers are related with the diet. Okay. You see, due to westernization, our diet has changed totally. We don't eat our normal diet of the region. We generally follow the change of diet will lead to the shift into the epithelial response, and that can lead to the development of the cancer. Coming to the Medina region, CRC is the number one cancer in the men and the third most common cancer in the women after breast and thyroid cancer. See, in our region where we are residing, CRC has become the most common cancer in the men. And the age is 60 to 70 years of the age. Our patient Fahad also was 65 years old. Okay. And usually when it is sporadic, less than 20% of the cases see before the age of 50. But if it is a family, you can see as early as between the 30s and 40s. Not the risk factor. The dietary factor is the most closely associated with the increased colorectal cancer rates. Okay. And why? Which are the dietary factor? Low intake of unabsorbable vegetable fibers, like low fiber diet and high intake of refined carbohydrates and fat. So from where we get the high intake of refined carbohydrates and fat from your like breads, pizzas, your fries, your pastries, your ice creams, your pastas, what you eat daily. Okay. And you don't take the vegetable, the normal vegetable, which is usually consumed at home. We usually don't take, we go for the refined fiber. Okay. So how does it affect? Because of the reduced fiber contents, you don't have the fiber contents into the your diet, that lead to the decrease in the stool bulk formation. When the stool bulk formation is not there, it will also alter the composition of the intestinal microbiota. So fiber will not one thing, they will alter the normal microbiota of the colon or intestinal microbiota, GIT microbiota. And second, they have reduced bulk of the stool. So stool, higher the bulk of the stool, that will lead to the this material to the intestinal mucosa, and that will lead to the cell injury and alteration, and that will lead to a cell to go into the neoplastic transformation. Another risk factor, family history of CRC. If someone has colorectal carcinoma, ovaries, endometrium, and breast in women, they have high incidence of colorectal carcinoma. Genetic factor, as we already discussed, FAC, FAPC, HNPCC, we'll discuss in the coming slides. History of diabetes, hypertension, and obesity. This also is closely related with the dietary intake. Okay, those have abnormal diet, they have diabetes, hypertension, and obesity, and it will in turn lead to the increased CRC risk. Someone suffering from inflammatory bowel disease, especially the ulcerative colitis, high risk of colorectal carcinoma. A history of radiation therapy for prostate cancer or any other intra-abdominal cancer, exposure to radiation will lead to the increase. There is one mechanism is there, COX-2. This is the enzyme which like converts to prostaglandin E2. This prostaglandin E2 promotes epithelial proliferation. If you use the COX-2 inhibitors, especially the drugs, aspirin and other NSAIDs, which are COX-2 inhibitor, they have protective effect. So someone who has at the increased risk of colorectal carcinoma, we might start them with the low dose of aspirin as the inhibitor of COX-2 inhibitor, so that prostaglandin E2 should not be formed in the gut and epithelial proliferation can be stopped. So these are all the causative effect, and this aspirin and NSAIDs have the protective effect. Clear? Is it clear for you all or not?
Yes, it is.
Now you can understand in a better way about the risk factors of the colorectal carcinomas. Okay. Now the molecular pathogenesis. So these are all the risk factor ultimately leading to the genetic alteration. There are the two molecular pathogenetic mechanism of the colorectal carcinoma. One is the adenoma carcinoma sequence. Another one is the microsatellite instability. So go for the adenoma carcinoma sequence. Between 70 to 90% of the colorectal carcinoma arise from adenomatous polyp. Okay, first they have a adenoma, then this adenoma will go dysplasia and they go into the carcinoma. The adenoma carcinoma is a multi-step process, okay, and it has involvement of various genes, okay, like mutation, deletion, tumor suppressor gene, oncogenes, the signal transduction genes, the angiogenetic mechanism, the gene leading to the invasion, all these things go. Polyps, as we already told, polyps with the tubular histology pattern have least malignant potential, while the villous adenomatous polyp have highest malignant potential. The larger the polyp, more than 2 centimeter, the greater the size has the most important, followed by the histological pattern, which we already discussed earlier. So what happened over there in the adenoma carcinoma chances? Okay, first there is normal epithelium. Normal epithelium goes into the hyperproliferative or hyperplastic epithelium. Early adenoma, intermediate adenoma, late adenoma with dysplasia, or we can say adenoma with moderate dysplasia, mild dysplasia, moderate dysplasia, severe dysplasia, carcinoma. And what happened over here? There is loss or mutation of APC gene. Okay, loss of DNA repair or DNA methylation gene, mutation of the RAS gene on the chromosome 12p, tumor suppressor gene loss, especially p53 gene or other tumor suppressor gene, loss of p53 gene on the chromosome 17p. This is all multi-step mechanism at the level of epithelium and at the level of molecular. will lead to development of from a normal epithelium to a carcinomatous epithelium. So mucosa, this is the normal colon. Okay, so mucosa at the risk when you have got the germline mucosum as an inherited mutation in the APC gene, or you have, like, this is the first hit. Okay, then there is methylation abnormality or inactivation of the abnormal allele, like loss of APC gene in the both beta through the beta catenin. Okay, so there is hyperplasia. There is various proto-oncogene mutation, especially the oncogene KRAS activation, development of an adenoma. Then there is a loss of P53. So normal type of wild type of P53, oncogene induced adenoma sequence. This adenoma go sequentially changes in the mild to moderate dysplasia, where also here loss of P53 gene will lead to development of the carcinoma. So this is the multi-step carcinoma at the epithelial level, at the molecular level. Now the second mechanism is the microsatellite instability. What is microsatellite? This is like they are the molecular signature of the defective DNA mismatch repair. Okay, the microsatellite send the molecular signals so that there is, whenever there is a defect in the DNA, and these microsatellite, when the signals go to the genes come and they repair the DNA. When there is an instability in the microsatellite, there will be a defective DNA repair. Okay, and the mutation in the colorectal carcinoma are the gene are the MSH2 and MLHL are found in the sporadic carcinoma, and MSI in the familial HNPCC. Okay, so these are all the DNA repair gene, but MSH2, MLH1 in the sporadic cancer, while MSI with microsatellite instability with the MLH2 and microsatellite instability with the HNPCC. So in both sporadic as well as inherited, you find the microsatellite instability and involvement of MSH2, MLSH1. So 90, 80 to 85 to 90% of the sporadic cancer due to involvement of the APC gene. 10 to 15 of the sporadic cases due to involvement of the DNA mismatch repair gene. Okay, so these DNA mismatch repair gene, there is the defective DNA repair. Okay, and this defective DNA repair, DNA is not repaired properly. The defected DNA has gone into the cell cycle and there is development of the gene. Okay, so you have MSH2, MSH6, MLH1. These are the very, very important gene, especially MLH1, which is one of the most commonly involved in the sporadic colon cancer. So this is MMR pathway or mismatch repair gene pathway or microsatellite pathway. There is a normal cone, normal mucosa, mutation in the repair gene, MSH2, MLH1. There is, like, here you get the sessile adenoma. Okay, then there is again continuous microsatellite instability, accumulation of another mutation which regulate the gene growth, like oncogene, tumor suppressor gene like TGF beta, BAX, apoptosis, activation of BRAF. This is also BAX and BRAF are the apoptosis gene. Tissue growth factor beta is the growth factor oncogene. This will lead to development of the carcinoma over here. Okay, here also normal colon, adenoma, carcinoma. This is mismatch repair gene or microsatellite instability pathway. So pattern of sporadic and familial colorectal carcinoma. Familial, these are the hereditary and this is sporadic. Hereditary, you have two spectrum. Familial adenomatous polyposis. This is APC WNT pathway involved genes are APC gene located on chromosome 5, hundreds of adenoma, adenocarcinoma. Hereditary non-polyposis colorectal cancer, involvement of DNA mismatch repair gene, MSH2, MSH6. See, in the hereditary, you have involvement of MSH2 and MSH6 gene, and it will lead to the adenoma and the mucinous adenocarcinoma. Here, just plain adenocarcinoma. Here, mucinous adenocarcinoma. While we go to the sporadic, same genes are involved. Majority of APC-WNT pathway, but here mutation in the somatic cell, not in the germline mutation. Okay, here you see the left side adenocarcinoma, while you have sporadic mismatch repair MLH1 gene, here the right side adenocarcinoma. Okay, understood this slide clearly?
Yes, doctor.
The same gene is involved in both. Okay, both in the hereditary and the sporadic. FAP, adenoma, adenocarcinoma, DNA mismatch repair, MSH2, MSH6, adenoma, mucinous carcinoma, sporadic cancer. 80% of the time it is APC, left-sided adenocarcinoma. Same over here also. These familial adenomatous papulosis colon is more common than HNPCC. Okay. Here also it goes 85 to 80%. Here also it's 10%. Here also 80%, 10 to 15%. DNA mismatch repair. But here you see in the hereditary non-polyposis colon, MSH2, MSH6, while in the sporadic colon involving the DNA mismatch repair gene, MLH1. This is the high level questions which you can have in your um, SMLE or USMLE exams. Okay, so that's why I have included this over here. Okay, and the left sided adenocarcinoma, if you see, it's mostly due to the APC involved. Right sided mucinous carcinoma, mostly due to the DNA mismatch repair MLH1 gene. So colorectal carcinoma in the either hereditary and sporadic, 80% of the time this is mutation in APC gene, adenoma carcinoma pathway, further mutation in KRAS and P53 gene. 10 to 15% microsatellite instability or mismatch repair